I think. So last week, my sister underwent TKR. So that's the reason I was busy in Bangalore. So we were not able to meet and then, have our class. So today there is no problem at all. So and that too, she developed a side effect also of opioid-induced side effect. We'll discuss that also today. Anyway, that was
Okay, sir.
an experience also we had with intrathecal morphine, of course, minimal dose of intrathecal morphine.
Okay, sir.
So today, what we'll be discussing is we'll be discussing about opioids, everything about opioids. And
Yes.
opioids, briefly about the history, nomenclature, and then we will discuss about the classification of opioids, then their mechanism of action, then pharmacokinetics of opioids, then pharmacodynamics, then individual opioids we'll discuss in briefly. The most important individual opioids like everyday what we use, like morphine, fentanyl, remifentanil, and new drug, which is again in the now available in India. So we'll have to discuss about remifentanil. Buprenorphine, I don't know whether you people are using buprenorphine at all. In your
We are
practice,
using, sir. We are using, sir.
you are using buprenorphine. So mostly, I think intrathecal buprenorphine you must be using.
Yes, sir.
Isn't it?
Interesting. We are
May
using.
not systemic buprenorphine.
Very rare, sir.
I don't think you will be using IV buprenorphine.
No, sir. We are using intrathecal buprenorphine.
Yeah, intrathecal epidural buprenorphine we will be using.
Yes.
So we'll also discuss briefly about buprenorphine and other drugs like pentazocine, nalbuphine, butorphanol. These are agonists, antagonists also. Then naloxone, briefly, if time permits. And then after the individual drugs, we'll also discuss about the clinical uses of the opioids. We would have discussed in our discussion, and also separately also we'll discuss about the the clinical uses of opioids.
Okay, sir.
Okay, coming to the nomenclature and brief history, you all know that opioids are being used since thousands of years, isn't it? Especially the extract of papaver somniferum. Yeah, why the name opioid? There are opes. What is the meaning of opos? Why the name came as opioid or opiate? And what was, what do you mean?
Greek.
Greek.
It's a Greek.
No, Greek word only. What is the meaning of Greek word opos?
Stupidity.
Now, opos means juice.
Juice.
No, morphine and opiates are extracted from the juice of papaver somniferum. That is the plant papaver somniferum. From that juice, it was they extracted originally, and still morphine is extracted from the juice of the papaver somniferum only. So the other important thing is the difference between opioids and opiate. What do you mean by opiate? Many times these nomenclature will be using. So just I wanted you to know about what do you mean by an opiate and what do you mean by an opioid.
The drug that derived from opium is called as opiates.
Now, opiate means the drug
Derived from opium.
Opium or from naturally occurring. That's
Naturally,
papaver.
naturally. Papaver somniferum.
Any drugs that are naturally derived from papaver somniferum, you call them as opiates.
Okay,
and opioids, what do you mean?
Opioids, the term narcotics there from opioids.
The narcotic can be other drugs also. It need not be only opioids.
Okay, sir.
What are the drugs?
Opiates
are narcotics.
Exogenous substances that are derived from opioids.
Opioids means all those drugs that act on opioid receptors. Like, mu kappa delta receptors, which are acting on the opioid receptors are called as opioids. So that is the difference between opiates. Opiates also are opioids. But when you say opiate, that is a naturally occurring or naturally extracted from the plant papaver somnifer. So that is the thing. And who used morphine? And why morphine? What is the why name morphine?
The Greek
Again,
goddess named Morpheus, derived from morphine.
Morpheus. Yeah,
Morpheus.
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 1806, sir.
No, what is this Morpheus? Who
God
is
of dreams. God of dreams, sir.
God of dreams? That is the reason why good that you have read a little bit about history also. And who used morphine, as an injection first? So Alexander Wood injected
Yes.
because, in 1853, because
That's
then
not.
the hypodermic needles and syringes were introduced during that time. So he extracted morphine and he injected for his patients to get good pain relief. So he used morphine as intramuscular morphine. But unfortunately, he also used intramuscular morphine to his wife, but he didn't know exact dose. So she went in for respiratory depression and died out. That was the first fatality because of, recorded fatality because of morphine. Okay, the next important, after this brief history, very important, many times you will be asked about classification of opioids. So invariably, this can be even a 10 marks theory question also. So how do you classify opioids? There are different kinds of classifications. There is not one classification. I think at least about 4 classifications are there. One classification is based on how they're manufactured.
Penanthralin and benzodiazepine.
Can you just tell how based on their manufacture?
Chemical classes, penanthralin and benzodiazepine classes has been classified.
No, based on their manufacturing means based on whether they are naturally
origin.
Yeah, naturally occurring.
Natural and synthetic.
Semi-synthetic and
Synthetic and synthetic.
so this is the way they are being classified based on how they are synthesized or manufactured. So one is the naturally occurring. So can you give some examples for naturally occurring?
Morphine.
Morphine and codeine.
Yes.
Codeine and morphine are naturally occurring. Semi-synthetic?
Heroin.
Heroin and methyl.
No, you said that you are using the drug intrathecally.
Buprenorphine.
Buprenorphine. So semi-synthetic is buprenorphine.
Yes.
And what is the actual heroin is not used, the name nowadays. What is the name that is used? Diamorphine.
Diamorphine. Sir.
Diamorphine. So diamorphine is same as heroin.
Yes, sir.
So it's usually used as diamorphine, extensively used in UK. Diamorphine for central neuraxial, analgesia. Diamorphine is one of the drugs that they use. Then, synthetic. So synthetic, again, how subclassification of synthetic? No, it is there in the...
Yes, sir. Levophenol, morphine is derived from levophenol, sir.
Morphinol derivatives, correct? Morphinol
derivatives,
is liverphenol is morphinol derivatives.
Yes, sir.
You have methadone derivatives. That is methadone itself.
Okay, sir. Yes,
This most often is used to relieve the patients from addiction of opioid addiction.
Yes.
That is used. Then we have benzmorphine.
Benzmorphine.
What are
Pentazocine.
Pentazocine.
Benzmorphine, correct? And phenylpiperidine derivative.
Fentanyl, sir.
Fentanyl, sufentanil, alpha, and even remifentanil. And pethidine. Pethidine was the first synthetic opioid that was introduced. The synthetic phenylpiperidine derivative of opioid that was introduced was pethidine. Okay, so now coming to the other classification based on their potency. Potency.
Okay, sir.
They can be classified as, potency means weak. Can you name weak opioids?
Weak opioids.
What about codeine? Is it strong opioid or a weak opioid?
Weak opioids.
It's a very weak opioid. And what about tramadol?
Tramadol,
Weak.
Yeah. And
Okay.
tapentadol?
Weak opioids.
Yeah, these are weak opioids. You can name some like codeine, then tapentadol and tramadol are weak opioids. Then we have the moderate opioids. Moderate opioids. Moderately potent.
Moderate.
Potent.
Paris.
Morphine.
Morphine.
Morphine, pentazocine. Then the other agonist, antagonists like butorphanol. All these are moderately potent and highly potent, strong opioids.
Fentanyl.
Yeah, all phenylpiperidine, especially other than pethidine. Like these fentanyl, sufentanil, alfentanil, remifentanil, all these are highly potent. And the third classification is based on the onset offset of action, onset and offset action. So rapid onset and offset, can you just give examples?
Fentanyl. Fentanyl is rapid.
Fentanyl is not rapid onset. It takes some time, isn't it? So we'll come to that. Remifentanil and alfentanil. Rapid onset and rapid offset also. That is very important. And then we have intermediate onset and offset.
Intermediate.
So fentanyl. Fentanyl, sufentanil, they are intermediate and onset and offset, and slow onset and slow offset.
Morphine.
Buprenorphine. Slow onset and slow offset. So that is. So one more classification is based on their affinity and their effectiveness on the receptors. So can you just classify them based on this particular
Agonist, antagonist, and
agonist. Yeah. Second is
agonist, antagonist.
No, partial agonist. Agonist, then partial agonist. Third is agonist, antagonist, and then antagonist. Fourth is antagonist. What do you mean by agonist means what? As such, an agonist means what?
It facilitates the receptors.
Enhance the action.
No, agonist means
Enhance
what?
the receptor.
Now, one is its association with the receptors. What about the association with the receptors? A strong or weak association with the receptors?
Strong association with the receptors.
Strong association with the receptors. And what about intrinsic action after it associates with the receptors? What about the effectiveness that it produces, effective intrinsic activity? Is it strong intrinsic activity or no intrinsic activity or partial intrinsic activity?
Strong
intrinsic. No, they are binding to the receptors is very strong. Strong association with the receptors. That means they have an attraction to the receptors, quite a strong attraction to the receptors. And second thing is, they also, the intrinsic activity is 100%. 100% association with the receptors and 100% intrinsic activity after association with the receptors. Okay, partial agonists. Now, can you give some examples for agonists?
Fentanyl,
morphine,
tramadol,
codeine,
fentanyl, pethidine,
tramadol, heroin,
tapentadol, all are agonists. They're all agonists at what receptor?
mu
receptor. They're all at mu receptor. Okay. Now we have partial agonists. The second thing is we said partial agonist. What do you mean by partial agonism? What is the meaning of partial agonism?
They intermediately associate with the receptors.
Now, what about the association with the receptor? Is it strong association, 100% association or partial association?
Partial association.
No, no. Association with receptors is 100%. They're strongly associated, they combine with the receptor. Combination, the attraction towards the receptors is 100%. Whereas after associating with the receptors, their intrinsic activity may not be 100%.
It's 50%.
It may be 50% or it may be 60%. It is partial. Intrinsic activity is partial, but association is 100%. Okay, now agonist, antagonist. What do you mean by agonist, antagonist? So again, partial agonist. We give
Buprenorphine.
Buprenorphine is a partial agonist. Already we have discussed. Okay. Yes. Then agonist, antagonist. What do you mean by agonist, antagonist?
Agonist with action, it facilitates the action of the. It binds to the receptor and facilitates action, sir.
Pardon?
It binds with the receptor and facilitates its action, sir.
Okay. Then?
So agonist.
No, called as agonist, antagonist.
Agonist.
No, what do you mean by agonist, antagonist? No, unless you know the meaning.
Enhance and inhibit.
Enhances the action of.
Enhance and inhibit reaction of.
You should know that agonists, antagonists are, they are agonists at one receptor, they are antagonists at other opioid receptor, because we have many opioid receptors, isn't it? So they are agonists at one kind of opioid receptors. They are antagonists at other kind of opioid receptors. Can you just give examples for agonists, antagonists?
Pentazocine, sir.
Yeah, pentazocine. Then
nalbuphine.
Yes, then
buprenorphine.
Not buprenorphine. Buprenorphine is
partial.
Yeah, partial agonist.
Partial. Butyrophenol.
They are all agonists at kappa receptors and antagonists at mu receptors. So these are the different classifications of opioids which you should always know about. Okay, after about classification, let us now briefly discuss about the pharmacokinetics of opioid receptors. Sorry, before that, mechanism of action, and before that, the opioid receptors. Where all they present also, opioid receptors. Now, what are the different opioid receptors you know about?
Mu2, delta,
kappa and delta.
Yeah, you have basically mu, kappa, and delta receptor. And before, in older books, if you see, sigma receptors are also there. The other receptor, now in modern books, sigma receptors is that name is not there. Instead of that, nociceptive receptors. One more receptors has been added, opioid receptors, which are called as nociceptive receptors. Now, these receptors, where all they are present, these opioid receptors? In the brain, where all the opioid receptors are present?
Yes, sir.
Now, where all the receptors are present in the brain?
Brainstem, spinal cord.
No, first brain and then spinal cord.
Okay. In brain.
The brain, where they are present? Where all they are present in the brain?
Rostrum of locus coeruleus and rostrum of ventral.
Yeah, locus coeruleus. Oh, no, you should know about locus coeruleus. What are the other receptors that are present in locus coeruleus, which are already we have discussed before? Locus coeruleus. What is this locus coeruleus? Where the other important drug of ours, which we extensively are using nowadays, also acts on these locus coeruleus receptors present.
Clonidine, sir.
Huh?
Clonidine, sir.
Clonidine, yes. What receptors it acts? Clonidine
alpha 2 receptors.
Yeah, because in locus coeruleus also, other than the mu receptors, a lot of these alpha 2 receptors availability. Why it is called as locus coeruleus? What do you mean by coeruleus? Now, just to probe you, that's all. Coeruleus means blue. That area of the brain in the pons it's bluish. and where, alpha-2 receptors are concentrated. That is why it's called as locus coeruleus.
Okay, sir.
Here again, you have the mu receptors. And where else, other than locus coeruleus?
Pre-aqueductal gray matter, sir.
Yeah, periaqueductal, not pre,
That's
periaqueductal gray
gray
matter,
Yes, sir.
extensively concentrated there. Then where
Rostrum
else?
of ventral medulla, sir.
Yeah, rostral ventral medulla. Then they're also present in the limbic system. They're also present in the cerebral cortex also.
Okay, sir.
And again, in the spinal cord, where the mu receptors are concentrated. In the spinal cord.
Substantia.
Substantia gelatinous.
The dorsal horn, and especially in the substantia gelatinosa. Substantia gelatinosa, or that is it is the second raphe. In the posterior, the dorsal horn of the spinal cord, these raphe are present, isn't it? So first, second, third, fourth, fifth, and like that. And second raphe and fifth raphe are important for pain transmission. And most important is the second one, that is the substantia gelatinosa. And mu receptors are concentrated in substantia gelatinosa. And again, where else? Peripherally? Peripherally, again, in majority of the neurons, the nerve endings, the opioid receptors are present. And again, in the gastrointestinal tract also. Gastrointestinal tract, they are present. And again, in the genitourinary system also, they are present. The mu receptors. Now, once you know that, they are present all over. So how the analgesia, what is the mechanism of action of these opioid drugs? How do they, after interaction with these receptors, how do they produce analgesia? What is the basic mechanism of action?
Opioid agonist and receptor that increases the potassium activation and close the calcium conductions, then which leads to decrease in neurotransmission.
No, because they have basically one thing is they inhibit adenyl cyclase. They are all these receptors. Actually, these receptors are G protein coupled receptors. Basically,
proteins.
Like you have beta receptors, alpha receptors. So all these are G protein coupled receptor complexes. So like that, adenyl cyclase inhibition is done by the opioids. By inhibiting adenyl cyclase, they decrease the amount of cyclic AMP. So by decreasing the cyclic AMP, they produce analgesia. One method of analgesia by decreasing cyclic AMP in the brain and spinal cord and also the peripheral neurons. The second thing is, especially in the spinal cord, presynaptically, as Aarti was talking about, presynaptically, they inhibit calcium channels. By inhibiting calcium channels, they decrease the release of neurotransmitters, especially the pain-producing neurotransmitters like substance P, and also glutamate. So the substance P and glutamate, they act on NMDA receptors. They activate these NMDA receptors and produce quite a bit of pain. So glutamate is an excitatory neurotransmitter. So by inhibiting calcium channels presynaptically, they decrease the release of glutamate and also, the substance P. The substance P is the one which is an excitatory neurotransmitter, which is very important as far as the transmission of pain is concerned into the spinal cord, isn't it? So they decrease this substance P in the peripheral, neurons also. They decrease the amount of substance P and glutamate. And postsynaptically, they activate potassium channels. So presynaptically, they inhibit calcium channels. And postsynaptically, they activate potassium channels. So once they activate the potassium channels, they decrease or they inhibit the neurotransmitter passage through the synapse. They inhibit the synaptic passage of these neurotransmitters, especially the glutamate and substance P. They produce hyperpolarization of the synapse by activating the potassium channel. So these are the different methods by which these opioids will produce directly acting on these receptors. The other thing is, from the medulla, because we know that, periaqueductal gray, we have mu receptors. The rostral ventral medulla, we have mu receptors. All these also have a connection to the spinal cord. They are inhibiting neuronal pathways. By activating these inhibiting neuronal pathways, these opioids, they'll decrease the reuptake of norepinephrine or noradrenaline in the substantia gelatinosa neurons. So they inhibit the reuptake of norepinephrine and also the serotonin. So they increase the levels of serotonin and norepinephrine in the spinal cord, and thereby they activate the inhibiting pain pathways. That's how they also produce analgesia. So these are the different mechanisms of analgesia produced by opioids. So this is very, very important for you to know about the mechanism of action. So next we'll discuss about the pharmacokinetics of opioids. So for pharmacokinetics of opioids, you have to know about the pKa, and then the protein binding, then the volume of distribution, and the lipophilicity. So these are very important, and where the metabolism, where exactly these drugs get metabolized, and what are the metabolic end products, and what is the significance of these metabolic end products. Okay, now can you define what is pKa and what is the importance of pKa as such?
Amount of which has been.
Now, what is pKa?
Look at the formula.
Pardon?
Ionized.
Now, what do you mean by pKa? So define pKa, because you have to use the Henderson-Hasselbalch equation for pKa, because when we discussed local anesthetics, we discussed in detail about pKa. Because one thing you should realize, all these opioid drugs are also weak bases, like local anesthetics. So because they are weak bases, if their pKa is away from the plasma pH of 7.4, more of the drug will be in the ionized form. The ionized form will not be able to cross the blood-brain barrier. That is very, very important. It is the unionized form is the one which can cross the blood-brain barrier. That is very important. So that is how, the pKa is defined as that pH at which the base and acid or ionized and unionized forms are equal in proportion. Otherwise, you can have the formula pKa is equal to pH multiplied by log of, ionized divided by unionized, where it is 50% unionized and 50% ionized. So log of ionized divided by unionized, or log of acid divided by base. If 50% acid is there or ionized is there and 50% unionized the base is there, 50 by 50 is 1. Log of 1 is 0. So pH becomes equal to pKa, or pKa is equal to pH. This is Henderson-Hasselbalch equation. So you should always remember about this particular Henderson-Hasselbalch equation. Many times you may be asked about this in your practicals. Application of Henderson-Hasselbalch equation. So very important. So pKa is equal to pH multiplied by log of acid divided by base, or ionized divided by. So if they are 50-50, that is 50 by 50 is 1, log of 1 is 0. So pKa is equal to pH. Suppose if the pH and pKa are same, then 50% of the drug will be in the unionized form and 50% of the drug will be in the ionized form. If the pK is higher, then less amount of the drug will be in the unionized form, and more amount of the drug will be in the ionized form. So what is the pK of commonly used drugs we'll discuss about? What is the pK of morphine?
7.9, sir.
Morphine is roughly 8. You are correct. 8. So what is the percentage of drug in the unionized form of morphine at 7.4 pH?
7.4, sir.
Yes, at 7.4 pH, what is the percentage of drug in the unionized form? Because it has got a pK of 8.
Equal to 8.
How much of the drug will be in the unionized form? It is the unionized form which is important for crossing the lipid barriers. It's only about 23%. 23% of morphine when you inject will be in the unionized form. Okay, what about fentanyl? What is the pK of fentanyl?
8.4.
Yeah, 8.4. Very good. So how much of fentanyl will be in the unionized form? Because it is still away from the plasma pH of 0.4.
35.
No, because morphine itself is 8, which is slightly closer to 7.4, but its unionized percentage is only 20.
23%.
So for fentanyl, it is still away, 8. You think it is higher than 23% or lower than 23%?
Higher than 20%.
So it has to be lower than 23%.
Lower than 20%.
Because it is still away from the plasma pH 7.4. If it is closer to 7.4, its unionized form will be higher, like 50% or so, like. Isn't it? So it is less than 10%. Fentanyl has got less than 10%. How about remifentanil? What is the pK of remifentanil?
7.3, sir.
7.1.
1.
7.1. So how much of remifentanil will be in the unionized form? Is it higher or lower? It is very close to
Close to pH, body pH.
plasma pH. Even
the
the pK is less than plasma pH. That means more amount of the drug has to be in the unionized form. Because almost 67% of the drug is in the unionized form. What about alfentanil?
6.5, sir.
Yeah, 6.5. So still lower than 7.1. So how much of the drug will be in the unionized form?
80%.
90%.
80%. 90%.
Alfentanil has got the lowest pKa, and hence it has got, almost most of the drug is in the unionized form. Alfentanil. That is how, alfentanil is very rapidly acting drug, like remifentanil, also rapidly acting. So both are rapidly acting drugs, alfentanil and remifentanil, whereas morphine is very much delayed onset of action. We'll come to that, the onset of action, what are the, different factors which influence the onset of action also. So now coming to the other thing is protein binding. So what about protein binding?
Morphine has 35%.
20%.
Yeah, very low, 20 to 40% is morphine protein binding. And which kind of proteins morphine and opiates usually get bound to?
Alpha-1 acid
Yeah,
glycoprotein.
because they are basic drugs. Majority of them are bound to alpha-1 acid glycoprotein and also albumin. Small amount of them also get bound to albumin. So that is another very important thing, because we know that less the protein binding and more the drug will be available as P concentration.
P concentration.
Okay, what about other opiates like fentanyl, alfentanil, remifentanil and all those?
Fentanyl
80%.
80%.
Fentanyl is roughly 84%.
84%.
And alfentanil?
90%.
Yeah, 92%. That is another, one thing is, it is most of the drug will be in the unionized form, but unfortunately, it is highly protein bound, isn't it? So free drug concentration may be less. That is that is the reason why you have to know both. It is not just the pKa, it is also the protein binding, which becomes very, very important. And another very important thing about these drugs, and remifentanil is about 84% protein bound. That is also highly protein bound. Except morphine, all other drugs are highly protein bound. Only morphine is just about less than 40% protein bound. So all these drugs are, because the majority of them are highly lipophilic, their volume of distribution is quite high because they get distributed to all lipid containing molecules. That is another thing. And one more thing you should also know about them is the context sensitive half-life. Context sensitive half-time or context sensitive half-life. So what do you mean by context sensitive half-time? Can you just define what is context sensitive half-time? Because many times when we discuss about drugs when you give as an infusion.
Yes, sir.
Now, TY is also becoming very popular. So drugs with lower context sensitive half-time, you can always use as an infusion, continuous infusion. So what do you mean by context sensitive half-time? Can you define?
Ability of them to reduce it half of its original value, sir.
No, you have to define it properly, isn't it? Can you
And
give a proper definition of context sensitive half-time? When I was just now a few minutes back, I was talking to you about, I gave you a clue also. Because it is only for drugs which are given as an infusion form.
Infusion. Yes, sir.
So can you now define what is context sensitive half-time?
Time taken for the drug to reduce its half of its original value when the stoppage of infusion occurs, sir.
That is what is context sensitive half-time. So when you are giving these drugs as an infusion form, and after you stop the infusion, the time taken for the drug concentration in the plasma to drop by 50%. That is called as context sensitive half-time. So that is very important because, if the context sensitive half-time is less, so definitely once you stop the infusion, the offset of action also will be faster. Like, can you just tell about propofol context sensitive half-time, though it's nothing to do with the opioids, because, invariably propofol and remifentanil are routinely nowadays are being used for TIVA. So we should know for both. Propofol, what is the context sensitive half-time?
4.
How do you calculate the context sensitive? No, all these things I have discussed already before because propofol is over. Now, why I am asking you is when you talk about like in the exams also, suddenly our discussion can move to you are thinking of only I'll be asked about only opioids. So suddenly the discussion can move to other drugs also. So that's why you should know about this. Propofol. With 1 hour, what is the context sensitive half-time? And 8 hours, what is the context sensitive half-time? 10 hours, what is the context sensitive half-time? So based on this only, the target controlled infusions are also, they calculate all these things. Very important for TCI pumps also. So you should know propofol 1 hour, it is 11 minutes. If you run propofol for 1 hour and you stop the infusion, so the time taken for the concentration in the blood to fall by 50% is 11 minutes. Subsequently, if after 1 hour, every 1 hour, after 1 hour is 3 minutes. Sorry, 4 minutes. After first hour, from the second hour onwards, it is 4 minutes. So now can you tell me after 8 hours, what will be the context sensitive half-time of propofol?
6 minutes.
No, first 1 hour it is 11 minutes.
7 minutes, sir.
Then 4.
Afterwards, every hour it is 4 minutes.
4 minutes. Okay, sir.
So total how much it becomes? 11 plus
11 plus
7 hours. Another 7 hours into 4.
18.
28. 7
28.
is 28. 28 plus 7.
28 plus 11 is 30, 39.
39. Roughly, that is why in majority of the books it is given as 40 minutes. They give us after 8 hours, it is 40 minutes. But they don't give why after 8 hours it is 40 minutes. But you may run propofol for 10 hours, 12 hours. Now it is easy for you to calculate, isn't it? So first 1 hour, you just calculate it as 11 minutes. And subsequently, for example, now for 10 hours, if you run it, 39 plus 8 minutes, 47 minutes, isn't it? So that's how for propofol. Yes, okay. Now for remifentanil, what is the context sensitive half time?
4, sir.
Yeah?
4.
4
4.
minutes, even less than 4 minutes.
4 minutes.
It is just 2 to 3 minutes. Context sensitive half time of remifentanil. Okay, now I run remifentanil for 2 hours for one patient. I run remifentanil for another patient for 15 hours. So after 2 hours, what will be the context sensitive half time? And after 15 hours, what will be the context sensitive? For remifentanil.
2.
Now, these are very important things you should know about the opioids. So irrespective of whether you run for 2 hours or 10 hours or 15 hours, it is same, less than 3 minutes. That is the fantastic thing about remifentanil compared to all other opiates. That is why the rapid onset offset is also very rapid with remifentanil. So that's how it's one of the wonder drugs that has been introduced, and that is actually revolutionized anesthesia. Are you using remifentanil in your institution?
No, sir.
Not started using.
Started, sir.
So you can always ask your head of the department to get some remifentanil because it is available now in India, no problem. Because I was one of the principal investigator for remifentanil trial in India. Principal investigator for remifentanil trial because the remifentanil has to be, before introducing remifentanil in India, it has to be tried on Indian patients, isn't it? So theme is actually introduced remifentanil in India. They wanted us to multiple centers in India were given this task of doing a trial of remifentanil for our Indian patients. So actually, we received remifentanil vials from Themis. So actually, I was the principal investigator for my hospital. So we actually studied in 60 patients. And overall in other centers, almost about 11 or 12 centers were recruited in India. Now in 2024 September issue or October issue, that has also been published also in our IJA about remifentanil. This particular, the study trial, what we did. And after that only the government of India has given approval based on this trial, and now it's available in India for use. So remifentanil, why you should know is this, the context sensitive half time is very, very short. So that is one thing. What about, alfentanil, context sensitive half time?
60, sir.
Now it is also very short, just like fentanyl, about 5 minutes.
5 minutes.
Slightly longer than remifentanil, but it also, doesn't vary much. Alfentanil, context sensitive half time is very, very short. What about fentanyl? Because, fentanyl, have you used fentanyl as an infusion? You must have used fentanyl as an infusion in ICUs.
ICU,
Isn't it? Many times
yes.
in ICU, ideally remifentanil should be used, but fentanyl also has been used as infusion in ICU. So what about fentanyl? What about its context sensitive half time? Is it short or long?
It's long, sir.
It again depends on the duration of infusion. If the duration of infusion is longer, the context sensitive half time is also very long and it's quite cumulative. It's quite cumulative. That's why, fentanyl, you should be careful when you're using as an infusion. So that's about the context sensitive half time of these drugs. And now coming to the metabolism, where these opioids, majority of them get metabolized.
Liver, sir. Liver.
Yeah, all of them get metabolized in the liver except which drug does not require liver for its metabolism?
Fentanyl.
No, you should have known about this. Remifentanil.
Remifentanil.
Yeah, remifentanil, non-pseudocholinesterase esterase hydrolysis in the plasma. So plasma esterase hydrolysis, ester hydrolysis, but non-pseudocholinesterase. It does not depend on pseudocholinesterase. Non-pseudocholinesterase ester hydrolysis with remifentanil. So metabolism is in plasma itself. That's why, that's duration of action is also very short because it rapidly gets metabolized in the plasma itself. So you can say you can consider it as an ultra short acting opioid, so that you have a total control. So you just stop it, and the effect also goes off. You're giving as an infusion, you just stop it. So the analgesia, respiratory depression, whatever it may be, all the effects of remifentanil just goes off just about 3 to 5 minutes. That's all. Ultra short acting. So that is an advantage with remifentanil. But all other opioids, they require liver for their metabolism. So what kind of reaction? Is it phase 1 reaction or phase 2 reaction in the liver they undergo? Or both phase 1 and phase 2? Or certain drugs only phase 2 reaction?
Morphine and
conjugation. One thing you should realize, phase 2 is conjugation. With glucuronidation, otherwise called as glucuronidation. Phase 1 is, dealkylation, N-dealkylation, N-demethylation, the hydroxylation, oxidation, all these reduction, all these are phase 1 reactions. So what about majority of the opioids?
Both phase 1 and phase 2.
Yeah, majority of them are both phase 1 and phase 2, except which drug does not undergo phase 1. Directly it undergoes phase 2.
Morphine, sir.
Morphine, yes. Morphine is glucuronidation is method of metabolism. Morphine. So
morphine 3 and morphine 6
is metabolized in the liver. Only any small quantity can be excreted and changed in the kidneys. So what are the metabolites of morphine?
Morphine 3 glucuronide, morphine 6 glucuronide, sir.
Yeah, very good. So morphine 3 glucuronide and morphine 6 glucuronide. How much of morphine 3 glucuronide will be there, and how much of morphine 6 glucuronide will be there?
Majority will be morphine 6 glucuronide only, sir.
What about Aarti?
Morphine 3 somewhere.
Now, if I am asking again, another question when you are answering, so there should be, that means your answer is not correct, isn't it?
Thank you, sir.
So majority is 3 glucuronide. Almost 70 to 80% is 3 glucuronide. Only 6 to 10% is morphine 6 glucuronide. Now, what about these metabolites? Do they have any pharmacodynamic effect, or they don't have any active metabolite or inactive metabolite?
In 6 glucuronide is active metabolite.
Yeah, very good. So morphine 6 glucuronide is active metabolite. It has got an analgesic
property also.
And also respiratory depression also.
Respiratory depression.
Why should you know that about morphine 6 glucuronide? No, where actually normal people, it hardly matters, this 6 glucuronide, isn't it? So where it matters a lot, in which kind of patient, where it can get accumulated and can even produce severe respiratory depression, though it is only 6 to 10%. How it is treated? This morphine 3 and 6 glucuronide, how they get excreted out from the body? Is it through the bile or through kidney?
Kidneys.
The majority through kidney, and a small amount, they are also, excreted through bile, and they undergo enterohepatic circulation. A small amount, very small amount, minor amount, are excreted through bile, enters the intestine. They get converted to morphine again, and then re-enters the circulation. Very small quantity, but majority of these 3 and 6-glucuronide are excreted through kidneys. For example, a patient has got kidney failure and you're using morphine. Any problem in such patients?
Yes,
It accumulates,
Opioids
it
cause
accumulates in
Yeah,
renal failure
such
patients.
patients with kidney failure, morphine 6-glucuronide, though it's small quantity, but it can get accumulated, and that can produce, respiratory depression in these patients. So the dialysis will help in, excreting morphine 6-glucuronide if such is the problem in such patients. Okay, what about the oral morphine? How about
Chronic.
oral morphine?
Chronic ill patients who is having treated with cancers,
No, majority of the times, in
palliative
patients,
patients.
yeah, for cancer patients, you also give oral morphine, isn't it?
Morphine.
So what about the pharmacokinetics of oral morphine? What is the bioavailability of oral morphine? Does it undergo, majority of it undergoes metabolism in the liver before it enters into the circulation? No, it has to, oral means gets out, and then all of them have to enter, through the portal vein. Every drug has to enter the liver, isn't it? And their first pass metabolism, what we call it as. Now, what about first pass metabolism of morphine? Does it undergo a lot of first pass metabolism or doesn't undergo?
Limited first pass metabolism in liver.
Everything, somehow you are answering the opposite. Now it undergoes maximum first pass metabolism. That is why the dose required is much higher. One. And second thing is, because why I asked you about this is, the metabolic end product is morphine 6-glucuronide along with morphine 3-glucuronide. And it has been said that oral morphine, when you give, it is the morphine 6-glucuronide is the one which actually produces very good analgesia. So that is thought so. So that's about the morphine. What about fentanyl? How, again, fentanyl gets, metabolized? Is it phase 1 and phase 2 or phase 1 only or phase 2 only?
Phase 1, sir.
Majority undergoes phase 1. What is the metabolic end product of fentanyl? It is norfentanyl because it undergoes N-demethylation. So norfentanyl is the metabolic end product. And is it an active metabolite or inactive metabolite? Norfentanyl.
Inactive metabolism.
Yeah, it's inactive metabolite. So no problem as far as fentanyl is concerned. Okay, how about pethidine? Pethidine is another drug what we using nowadays. We don't use it much except for shivering.
Shivering purpose.
Pethidine is not much used, though it's a strong mu agonist. So what about pethidine?
Phase 1, sir.
Yeah, again phase 1, norpethidine.
Not
Is it active metabolite or inactive metabolite?
active metabolite, sir.
So active metabolite, what does it produce? What does it? What is the
seizure effects?
seizures? Yeah, it's the central nervous system. It excites the central nervous system, so it can produce seizures. So norpethidine. So that is one important thing. And these drugs again you will have to, because many of these drugs are also used in for labor analgesia, isn't it? Like fentanyl is used. Remifentanil is nowadays is regularly being used. IV remifentanil as for labor analgesia in those patients where central neuraxial blocks are contraindicated for labor analgesia. Like patients with severe cardiac disease where they do require labor analgesia, but you cannot use central neuraxial block because by using because sympathetic blockade is a problem, isn't it? So in such patients or in those patients where there is a severe kyphosis, scoliosis is there, where they are able to get into the central uric axis. In all our patients who do not, one of the absolute contraindication for central uric axial blocks is the patient, the patient says no, you cannot give, isn't it? So that is one of the most important contraindication is for central uric axial labor analgesia. So if the patient does not want central uric axial labor analgesia, then nowadays extensively used is remifentanil. So when you use these drugs, what about they're transferred across the placenta into the baby, and what is the effect on the baby?
Neonatal
Respiratory depression.
No, all drugs will produce respiratory depression. How about remifentanil? I told you remifentanil is nowadays extensively used for labor analgesia in intravenous route. It should not be used intrathecally or epidurally. It's of no use. So it is always used only intravenous route for epidural analgesia, sorry, labor analgesia, not epidural, intravenous. So because, it crosses 100, all these drugs cross very fast. Because they're highly lipophilic drugs, they cross immediately, except morphine. Morphine is more hydrophilic than lipophilic. So that is another important thing you should always know about. And all these drugs do cross. And remifentanil also gets metabolized in the fetus very rapidly. Contact sensitive half-time of remifentanil in the fetus is also just about 3 or 3.5 minutes. So when the baby is born, baby will not develop any respiratory depression because of remifentanil. But another drug which is commonly used is fentanyl. So fentanyl, when it is given intravenously, not by central neuraxial blocks, or because, labor analgesia, you always use fentanyl epidurally. So the amount of drug crossing to the baby is not much. That is why it is extensively used. But when it is used IV analgesia, and especially for cesarean section, if you are using fentanyl as a pre-induction drug, many times you will be using, isn't it?
Yes, sir.
Cesarean section, routine cesarean section, do you use opiates as
No, sir.
pre-induction
No, sir.
drugs or post? When do you use?
Post-induction. After baby
delivery.
deliveries.
After the baby is delivered, isn't it? In which kind of patients, sometimes you may have to use pre-induction for cesarean. What kind of patients? To suppress the intubation response.
Pre-eclamptic patients.
Very good. So in pre-eclamptic patients, that sympathetic response to laryngoscopy and intubation can be so high. It can even produce intracranial bleeds. Patient may not recover. That is why in order to suppress, you may have to use even higher doses. You may have to use 2 to 3 micrograms per kg body weight of fentanyl as a pre-induction drug. So, but when you use, just 2 to 3 minutes, they are going to cross the placental barrier. So, any problem for the baby?
Floppy baby syndromes.
No, respiratory depression, because it's going to, fentanyl, because you are using before extraction of the baby, and it is going to cross immediately. Normally, that is the reason why we don't use before extraction, isn't it? But in this situation, you have to use, but you have to tell the pediatrician of use, so that we should be ready with naloxone. So that is why you should know about this. So how about pethidine is also regularly being used for labor analgesia by obstetricians, because it can be used intramuscular. So they don't require river assistance. Many times they give intramuscular pethidine. So anything regarding pethidine and fetus as far as its pharmacokinetics is concerned? Because once you give pethidine, because pethidine, the advantages of pethidine for labor analgesia for obstetricians they use is that it has been found that it reduces the first stage duration. It has been found to reduce the first stage duration of labor. Second thing is it can be given intramuscularly. So, but when it is given intramuscularly, you should know when to give. Because when is the maximum amount of effect on the fetus or the neonate when it is born? After pethidine has been given to the mother. You know that it is between 2 to 4 hours after its administration to the mother. The maximum concentration of pethidine will be there in the fetus, 2 to 4 hours. That is the reason. Suppose if you think that ideally it should be given, if the mother is going to deliver within 2 hours, it is all can be given. Or if you think that it is going to take a long time, it is going to take more than 4 hours, then also you can give pethidine without producing much problems for the baby. But if the delivery occurs between 2 to 4 hours of administration of pethidine to the mother, so then the maximum respiratory depression can occur. One. The second thing is the duration of action of norpethidine. Normally in the adult patients, when pethidine is used, norpethidine has got a duration of action of just about 2 hours or 2 to 3 hours. Whereas in a baby, it can go up to 24 hours in the neonate. So that is why, you should be careful about using pethidine in mothers for labor analgesia. So these are important things about the pharmacokinetics of the opioids. Then coming to intrathecal opioids, pharmacokinetics. Intrathecally, normally the gold standard opioid that is used for intrathecal purposes is morphine. It is a gold standard. And even for knowing the potencies of all drugs, it's always, compared with morphine. Like how much potent is fentanyl when compared to morphine?
It's more potent than
Pardon? How much more potent than morphine is fentanyl? It is 100 times more
100
potent.
times.
100 times more potent than morphine. And what about pethidine compared to morphine?
Morphine is more potent than pethidine.
Yeah, 10 times less potent than morphine. Pethidine. Okay, fentanyl is 100 times more potent when you use it systemically. Systemic administration, fentanyl is 100 times more potent. When it is administered intrathecally, what is the relative potency of fentanyl to morphine?
Morphine will be more potent.
No, morphine is more potent, or fentanyl is more potent.
Fentanyl.
How much time? Now 100 times it was more potent when it was being used
IV.
systemically. Now when it is used, it is only 4 times more potent. So this difference you should always remember about as far as intrathecal administration, because most commonly used intrathecal drugs, what we have is, you use morphine, you use buprenorphine, you use fentanyl. How much more potent is buprenorphine when compared to morphine? Normally.
10.
Pardon?
10 times. Morphine is 10 times more potent than buprenorphine.
Yeah. You have seen buprenorphine ampules?
Yes,
Yes, sir.
No, it comes in 2 ml ampules, isn't it? Each ml is how many?
0.3.
0.3
mg.
in 1 ml or 2 ml?
1
You are correct. 300 micrograms per ml.
Yes, sir.
Okay. What is 1 ml of morphine? How many
150
milligrams?
150 mics. 150 mics, sir.
1 ml of morphine, I am asking.
50.
Hey, you have not used morphine at all, or you have used morphine?
Morphine, yes, sir.
Morphine.
You have used. So you should know 1 ml of morphine contains how many milligrams?
15.
1 ml of morphine is 10 milligrams.
Okay.
The olden days, it used to come as 16 milligrams per ml. Now we don't get 16 milligrams per ml. We get 10 milligrams per ml of morphine. So you are getting 10 milligrams per ml of morphine, but 300 micrograms of buprenorphine, which is more potent. Now, when you are getting a drug in micrograms and another drug in milligrams,
Morphine, sir.
Morphine.
which one has to be more?
Morphine is more potent, sir.
Now, when you require very small quantity of the drug to get the same effect, or another drug you require in milligrams to get the same effect, which one will be the more potent?
Microgram.
So, buprenorphine is 33 times more potent than morphine. It is 33 times more potent than morphine, but intrathecal buprenorphine potency is same again, 33 times, unlike fentanyl. Fentanyl intrathecal potency is 4 times that of morphine. But systemically, when you give subcutaneous, intramuscular, intravenous, it is 100 times more potent, fentanyl. So, because these three are the drugs commonly used intrathecally, you should always know. So that is why. But what about the intrathecal when you give the drug? What about the pharmacokinetics of these intrathecal drugs? What happens to these drugs? Because basically I told you only morphine is the one which can be more hydrophilic than lipophilic. It is less lipophilic, it is more hydrophilic. Whereas all other opioids are highly lipophilic. So we have 3 drugs now can be used intrathecally. Now we are just now discussing buprenorphine, fentanyl, and morphine. Morphine, I told you, it is less lipophilic, more hydrophilic. Whereas buprenorphine and fentanyl are highly lipophilic. Highly lipophilic. So what happens to pharmacokinetics of these drugs when they are given in the central neuraxis, whether it is epidurally or intrathecally? Now, because when you talk about pharmacokinetics, you should know about the route of administration and their effect. That's why we discussed about oral morphine and then intravenous systemic morphine, and also now the intrathecal. Opioids. Morphine being hydrophilic, it doesn't get into the circulation easily. Once you inject either epidurally or intrathecally, it remains there only for a long time. Unlike highly lipophilic drugs. Highly lipophilic drugs, they just enter into the blood circulation, and their effect may be more supraspinal than spinal. They also have a spinal effect, but more because they enter into the systemic circulation, they go to the brain, they act on the supraspinal mu receptors, whereas morphine acts mainly on the spinal cord mu receptors. That is why, morphine is one of the gold standards. And other important thing is morphine, because it is more hydrophilic and because it stays in the spinal cord or in the spinal circle, there only in the central neuraxis for a long time, the dose required is much less. So this is one thing you should always know about. The dose required for morphine, when you give systemic morphine, for example, IV morphine, subcutaneous morphine, it is usually 100 micrograms per kg body weight, or 0.1 milligram per kg body weight is the dose of morphine when you give systemically IV subcutaneous morphine. But when you give intrathecally, it is not 100 micrograms per kg body weight, it is just 100 micrograms. It is just 50 to 150 micrograms. You don't go beyond, usually 150 micrograms in Asian population, because Asian populations are extremely sensitive to opioids. That is why you have to be extremely careful with Asian population how much you give these opioids. They're extremely sensitive. Slightly higher dose, they go for respiratory. That is one thing you should always realize. So intrathecally, when you give hydrophilic drugs, the dose requirement is very less because they stay there. They don't enter into the systemic circulation and they have, they don't get metabolized faster. So whereas the lipophilic drugs like fentanyl or buprenorphine, so they also have some effect on the spinal mu receptors, but most of the effect can be in the supraspinal mu receptors. That is another very important thing. So they get also metabolized faster also. Like fentanyl, what is the duration of action of fentanyl when you give intrathecally? Does it produce a prolonged duration of action?
2 to 4 hours.
No, less than 2 hours.
2 hours.
When you give intravenously, what is the duration of action of fentanyl? Intravenous. Duration of action of single bolus dose of fentanyl.
10 to 20 minutes.
No, duration of action. I'm not
Duration,
asking.
okay. 45 minutes.
No, it is again 90 minutes to 120 minutes.
90 minutes.
Fentanyl also, the duration of action is just about 90 minutes to 120 minutes. The same duration also in the intrathecal route when you give. Whereas morphine, when you give intrathecally, what is the duration of action?
24 hours. 12 to 24.
More than 24 hours, 24 to 36 hours. So that is the advantage of morphine. That is why I told you morphine is a gold standard. So you can just give intrathecal morphine, which can act for a prolonged period. Whereas when you give fentanyl, and fentanyl majority of the times is not used alone intrathecally. It is always used with the local anesthetic. Whereas morphine can be given alone. You don't have to use local anesthetics also when you give morphine. Like, for example, a cardiac surgery is going on. Now the patient requires cardiac surgery. Now people are using now intrathecal morphine. Though patient is requiring a cardiac surgery, they are not putting an epidural, thoracic epidural catheter. A single shot intrathecal morphine. And it is going to produce a prolonged duration of analgesia. One more thing about morphine is it does not depend where you inject. It is not that, segmental analgesia is not there. So it produces analgesia for all the segments of the spinal cord once you inject. That is an advantage. So for a child or adult patient, when you are using, when they are posted for cardiac or thoracic surgeries, nowadays very popular now is intrathecal morphine. Whereas you are also using, fentanyl for along with local anesthetic as an adjuvant through intrathecal route, isn't it? So how fentanyl is going to help, though its duration of action is less than the duration of action of BPOK.
Stop rate to
4 hours, whereas fentanyl is going to act only for 2 hours. How it's going to help as an adjuvant for intrathecal purposes.
post-operative analgesia.
Now, how can it produce post-op analgesia when it is acting only for 2 hours? If you're using morphine, post-op analgesia for 24 hours. So when you're using, fentanyl,
Prolong the duration of.
why are we using fentanyl for along with the BPOK? When you know that BPOK acts for 3 to 4 hours intrathecally, whereas fentanyl acts for only 2 hours.
Prevent hypotension, hemodynamic.
With hypotension.
For setting the level.
Because of BPOK, whether you use fentanyl or whether you don't use fentanyl, sympathetic blockade does occur and hypotension will occur.
To prolong the duration of surgeries, for setting the level.
No, duration of action of BPOK may not be much prolonged when you use fentanyl, because fentanyl duration of action is much shorter. Now, there are two kinds of, pain transmission to the spinal cord, isn't it? So one kind of pain transmission is through the, A delta fibers. Another kind of pain transmission to the spinal cord and to the brain is through C fibers. That you all know, isn't it? And A delta fibers are very small myelinated fibers, whereas C fibers are very thin non-myelinated fibers. And A delta fibers carry what kind of pain? Is it the first pain or second pain? Nowadays, they call it as first pain and second pain. A delta fibers carry, is it the first pain or the second pain?
First pain, sir.
What do you mean by first pain? So you should know, before answering, you should know what is first pain and second pain. First pain is, the nociceptive pain. That is like, the pinpoint pain which can be pinpointed. Like, like for example, I prick you. And when I prick you, you know exactly where the prick is, isn't it? With a pin, which can be really pinpointed pain. That is through the A delta fibers. So that is called as a nociceptive pain, which is carried through A delta fibers. Whereas the visceral pain, which is very vague pain. So, you ask somebody with abdominal pain, you ask exactly where he has pain, he'll show like this with the hand. No, he cannot pinpoint, isn't it? So visceral pain is through C fibers. C fibers pain is diffuse pain, is a second pain. It is sometimes called as a second pain. And A delta fibers, there is a nociceptive, it's a pinpoint, very short pain is A delta fibers which carry. So that's called as a first pain. Now the first pain can be easily blocked by which kind of drugs? Which kind of drugs are very effective in this nociceptive or the first pain or the sharp pain carried by A delta fibers? It is the local anesthetics. Local anesthetics are very effective in blocking this, pain carried by A delta fibers. Whereas the visceral pain, which is carried by C fibers, local anesthetics are not at all effective. Whereas opiates are very effective in blocking the transmission of the pain carried by C fibers, that is a visceral pain. But they are not very effective in blocking the pain that is carried by A delta fibers. Now you understood, isn't it?
Yes.
Now, one drug is very effective in blocking the pain which is carried by A delta fibers. Another drug is very effective in blocking the pain transmitted through the C fibers. That means the visceral fibers are better blocked by opioids, whereas the somatosensory pain or somatic pain or the nociceptive pain or somatic pain is very effectively can be blocked by local anesthetics. Now, if you combine these two drugs, now you can block both the kind of, pain transmission, isn't it? Both the pain that is transmitted through the A delta fibers and the pain transmitted through the C fibers can be effectively blocked. That is why a combination of an opioid along with local anesthetic is definitely much better in producing anesthesia, in producing very good analgesia. That is how labor analgesia. Now before, when we were using labor analgesia, maybe in 70s, 80s, we were not combining with fentanyl. We were using only bupivacaine. Then you had to use high concentration of bupivacaine. 0.25%, 0.5%, invariably motor blockade, invariably used to end up with cesarean section. So once we started combining, because in the labor analgesia, you should know that in only the first stage and early second stage, is always, it is the visceral pain. And from the second stage onwards, it is always somatic pain, where, perineum starts,
Yes.
dilating. So that is why for first stage, the early stage, and then that is the latent stage, and then the active phase of the first stage, it is the opiates are very effective. That is why when you combine opiates with local anesthetics for labor analgesia like fentanyl, intrathecal only fentanyl can be given, and afterwards epidural local anesthetics can be given from the second stage onwards or late first stage onwards, isn't it? So because the fentanyl is very good, opiates are very effective in blocking the visceral pain. That is why the C fiber pain is blocked by the opiates better.
Okay.
That is how, we always combine. You can give bupivacaine with fentanyl, even other regular surgeries, but you may not get a better post-op analgesia, but effective intraoperative anesthesia and analgesia will be there by combining fentanyl. But if you want to get a post-op analgesia, it is always better you go for bupivacaine with morphine. Bupivacaine with morphine. So that produces prolonged post-op analgesia. That's why for, I don't know, for TKR and all, you are routinely are doing total knee replacements and total hip replacements. So are you using intrathecal morphine for these patients? You have given anesthesia for, the TKR and THR? You're giving or you're not giving?
Morphine will be giving
We are not giving.
You're not giving morphine intrathecally. So now many people are now going in for intrathecal, even for cesarean section. Just intrathecal along with local anesthetic, intrathecal morphine, because majority of the cesarean section we do under spinal, isn't it? So you just give intrathecal bupivacaine with morphine, 100 micrograms or 50 to 100 micrograms for a cesarean section. Even for TKR or THR, you just give bupivacaine, 0.5% heavy with 3 ml or even isobaric bupivacaine or ropivacaine, and along with, for adult patients, about 100 to 150 micrograms of morphine. And you don't require an epidural afterwards. And you don't require an adductor canal block and all those things many times. Because this morphine produces extensive analgesia in the postoperative period, and the patients can be very comfortable. But one problem with morphine when you give intrathecally is, it starts ascending through the spinal cord. It remains in the spinal cord, starts ascending, and it may reach the brain very late. Very late. Usually after about 6 to 8 hours, it may reach the supraspinal new receptors also, but very late. Unlike other opioids, which are highly lipophilic, like fentanyl, buprenorphine and all, they don't go very late to the brain. So does morphine produce post-op? Somebody has asked some. Sir, does morphine produce post-op allergies after intrathecal injection? So we'll come to that. You asked this. So let me also discuss about this. So morphine, it takes almost 6 to 8 hours. That's what, when you are given morphine intrathecally, though majority of the books say that when you give doses less than 150 micrograms intrathecally, you don't have to monitor the patient post-operative. Majority of the books says, majority of the articles. But for Indian patients, it is always better to monitor the patients, Asian patients, Indian patients. They're extremely, especially the older age patients, and also patients who are female patients, female older patients. That is the reason why I just wanted to tell you that, my sister, I told you, she's 76-year-old. So last week, that's the reason why we did not have the class. I was busy there. So the anesthetist had used intrathecal morphine, along with bupivacaine, he had given 100 micrograms because we know that 100 micrograms will not produce much problem as far as respiratory depression is concerned. And also, epidural catheter was placed for continuous epidural infusion of, bupivacaine. So, but it was kept at just in the postoperative period, just kept at 2 ml per hour of 0.2% bupivacaine. But I was there. I knew that I had to monitor her because the post-op late respiratory depression can occur. And I was telling my son also about this, and invariably it happened. After about 8 hours, so she became drowsy, and the saturation started dropping, and the meiosis was there, and also respiratory. One thing about the respiratory depression we'll discuss in detail later. It is always the respiratory rate comes down first. And afterwards, the tidal volume also comes down, depending on the dose what we give. So her respiratory rate started dropping and saturation started dropping. She became more drowsy. Till then, she was fine. 6 hours, absolutely fine. She was very active, no pain, nothing. She was so happy. And she was able to move her both the limbs because motor blockade of bupivacaine had gone. And, we actually started bupivacaine much later because she had extensive analgesia. And unfortunately, they started becoming drowsy and was unresponsive, almost like. And, immediately, I called the anesthetist, who was my student only, and then got the naloxone, then gave her naloxone. And immediately, one thing about naloxone, when you give for morphine, when you had given through the central neuroaxis, so it won't antagonize analgesic effect. It will antagonize only the central respiratory because it will not act on the spinal cord. Because analgesia is through the spinal analgesia, spinal mu receptors. That is not antagonized by naloxone, but it will antagonize the central effect of morphine because the rostral spread takes a time. Rostral means, the upper spread. So, and we had to watch her because, the naloxone duration of action is 2 hours. So again, there can be repeat respiratory depression, but fortunately, there was no repeat respiratory depression. She was fine. So that is what you have to be careful about. In Asian patients, it is always you better, have to monitor these patients even post-operative period. So another important thing about the intrathecal opioids is another side effect is the pruritus. They don't produce any allergic reactions as asked by one of the students. They don't produce, but pruritus is one of the most common side effect of when you give these opiates intrathecally, whether it is fentanyl, buprenorphine, or morphine, or whatever the drug. I still remember because I used to use buprenorphine extensively for intrathecal use. When I was practicing when I was in Ballari, for about 15 years. So I used to have about 2 or 3 hours of sleep. Otherwise, hospital or outside practice. So one of the patients I had given buprenorphine. So many patients I used to give. Mild pruritus used to be there. But one patient, she had so much of extensive pruritus. She was, I was unable to control her. She was, scratching her hair like anything. So I had to give GA for hysterectomy. Posted actually, hysterectomy. And afterwards, after giving GA, I just, opened her few of the hair, this thing, scalp. I wanted to see a lot of lice, the lice in the hair. So that because of the lice and because the pruritus was, induced by, there was extensive pruritus for her. Otherwise, pruritus is one of the common problem of, when you give intrathecal or
Opiates.
oral opiate. So what is the antidote for this pruritus? How do you manage the pruritus when you give epidurally or intrathecally these opiates? And very common uh, problem. They may not produce the respiratory depression and all those things. That is very rare, but as long as you stick to the dose, what you give. Epidurally, you don't go beyond 2 milligrams of
2 milligrams.
morphine. But intrathecally, not more than, for Indian patients, it is always better to restrict to 100 micrograms, especially older patients. What drug can be given to,
Dexamethasone.
dexamethasone has been tried, but it won't help. They have used, two drugs can be used. One is, your 5-hydroxytryptamine 3 receptor antagonist,
IXT.
like ondansetron, granisetron, and all those things. They are going to prevent and, help also, treat also. The other drug is a pentazocine. For extensive pruritus, you can give just about 10 to 15 milligrams of pentazocine because it is a mu antagonist. Isn't it? Pentazocine is a mu antagonist. So probably the pruritus is because of the mu agonistic effect of these opiates. So you give a mu antagonist. Even naloxone, low dose naloxone also has been used. Low dose naloxone. But instead of that, pentazocine, about 10 to 15 milligrams of pentazocine can be given. Or other drugs that have been used are antihistaminics. Your CPM. With these drugs can be chlorpheniramine maleate or pheniramine maleate, Avil, all those drugs have been used. So this, pharmacokinetics of intrathecal or epidural opiates is slightly different. That is the reason why I just wanted to talk about when I was talking about the different routes. How about sublingual route? Sublingual buprenorphine is available. And transmucosal fentanyl, transmucosal lollipops are available,
Transdermal.
Fentanyl lollipops. Now again, they don't go through the oral route when you give. They directly, majority of them gets absorbed into the circulation. So the first pass metabolism is very less when you give sublingual or transmucosal, and even transnasal also. The first pass metabolism is very, very minimal. There is hardly anything. So the drug dose is almost same, like you give systemically, whether it is transmucosal or sublingual or transnasal. So these are a few of the things about the pharmacokinetics of these drugs. Now coming to pharmacodynamics. Any question you want to ask regarding the pharmacokinetics? Even rectal.
Transdermal.
Rectally also, many of these drugs have been used, especially for pediatrics. So again, the first pass metabolism is bypassed through the liver. So effective directly enters into the circulation and will be acting. And there is one more morphine preparation is there, especially used in the epidural space. Extended release morphine. That is, the trade name is Dipodure. Dipodure. So extended release morphine. That is, it is called as Dipodure. 5 milligram it comes. So what about this extended release morphine? Have you heard about extended release morphine?
Palliative care, they are given extended release morphine.
Epidural. So that, post-op analgesia. So it works for 48 hours to 72 hours. You must have heard about liposomal bupivacaine. Have you heard about liposomal bupivacaine? Local anesthetics, liposomal bupivacaine, which are incorporated in liposomal vesicles, these drugs. And when they are used for subcutaneously used local anesthetics in wound infiltration, they produce prolonged analgesia. Like that, extended release epidural morphine is, just like this only. In the lipid vesicles, the morphine is incorporated and it is introduced into the epidural space. Lipophilic morphine. Otherwise, it is a lipophilic morphine, which is called as extended release morphine or Depo-Dur, 5 milligrams. So when it is introduced into the epidural space as a single shot, it is not given as an catheter or anything, single shot, and it acts for almost 48 hours to 72 hours. 72 hours of or 48 hours of post-op analgesia. You don't require a catheter or anything. You just identify the epidural space and then inject extended release epidural morphine. So it remains there for a long period because it is present in the liposomal molecules. That is there. And 5 milligrams is enough for majority of the adult patients. 5 milligrams. And one important thing you should always remember when you want to use, you should not inject this through the epidural catheter. Extended release morphine. You have to inject only through the epidural needle, in a larger needle, like 18 gauge needle. And you have to inject very slowly. Because when you inject through the epidural catheter, it breaks out of the vesicles, the lipid vesicles. It's a liposomal morphine, isn't it? So, and when you inject rapidly also, breaking can occur. So it may not produce prolonged duration of action. Okay, so that care you have to take. You have to use a larger needle like 18 gauge needle and use it slowly, you inject it slowly into the epidural space. 5 milligrams is enough. So somebody asked a question, is any dose modification required? For what? I don't know. Can you just, Nitin has asked a question. So dose modification for what?
For liposomal morphine, he asked, I think so.
No, not for liposomal morphine.
Yes, for liposomal morphine only, sir. For liposomal morphine for the single shot, sir.
Yeah, single shot, it is 5 milligrams.
Okay, sir. Okay.
Comes as a 5 milligrams vial only, and you just draw 5 milligrams and inject. So that is not available in India, but just for you to know, for exam purpose, I just told you it's called as extended release morphine, which is used epidurally.
Okay, sir.
The other routes also you should always remember about the other routes of opioids. They can also be given, patches are there, transdermal patches.
Transdermal patches.
Like transdermal fentanyl is there, transdermal buprenorphine is also available. I think you may be using, isn't it? So one thing again you know about is they take a long time to get into the circulation and to produce their effect. So that is another very important thing you should always know about. So maybe 10 to 15 hours before only you have to put the patch for it to produce effective analgesia. And another is the transdermal iontophoretic fentanyl is also there in Western countries they use. Transdermal iontophoretic fentanyl. The iontophoresis means, it's an instrument is there. You just have to, it's again the transdermal route only. So, low current is produced through this equipment. Very low current, electrical current is produced, and that is going to push fentanyl molecules into the through the transdermal route into the circulation. So the effect is early. Why I want to tell you is it is not like regular transdermal patch. It takes 10 to 15 hours. This is much faster. It starts acting in just 1 to 2 hours. Transdermal iontophoretic fentanyl. So these are some of the advances regarding the drug route administration. I just wanted to tell you about. Okay, coming to pharmacodynamics of opioids. We'll just discuss in general pharmacodynamics of all the opioids and then go to individual opioids. So whenever we talk about pharmacodynamics, we'll start with the CNS, their effects on CNS. And before that, one thing you should always know about what is called as T half K capital E small O. What is this T half KEO? In majority of the books, it is there. They keep talking about this T half KEO. And whenever we talk about pharmacodynamics of opiates, this is very, very important. What is this T half KEO? Because one thing you should always realize, when you inject these opiates into systemically when you use it, so there is always a delay between the peak blood concentration and the peak concentration at the effector site. The effector site has to be at the mu receptors in the brain, isn't it? So the analgesia, usually they produce, when you use systemic opiates, they produce central analgesia, isn't it? They act on the mu receptors. Already we discussed where all these mu receptors are present in the brain. So they go there, they'll start acting. So, but there is a lag time between the peak concentration in the blood and the peak concentration in the effector site. And this is called as T half KEO. Otherwise called as, the plasma peak concentration to the effector site peak concentration constant, equilibrium constant. The plasma peak concentration to the effector site peak concentration, equilibration constant. So this is very, very important. So why it is important for us is, when you inject a drug, you should know, because what is very important is not blood concentration. What is very important is the effector site concentration in the brain. So all drugs are not same as far as the T half KEO is concerned. They differ in producing the peak onset. For example, T half KEO for fentanyl is how much? Because unless you know this, then only you know when to inject to produce analgesia. For example, now you are injecting fentanyl routinely as a pre-induction drug, isn't it? I think almost routine, unless you go for opiate-free anesthesia. Nowadays, opiate-free anesthesia is also becoming popular. Otherwise, majority of the times, as a routine, you inject midazolam, you inject fentanyl, you inject lidocaine, then you inject propofol. That is a routine thing, isn't it? So, because when you want to do an intubation, the maximum effect of your fentanyl also should be there, because it is one of the drugs which can inhibit or suppress this sympathetic response to laryngoscopy and intubation. So what is T half KEO of fentanyl?
90 minutes.
How many minutes?
90.
90. That means you have to inject 1.5 hours before.
15 to 30 minutes, sir.
No, usually when minutes before laryngoscopy and intubation you are injecting. Every day you are practicing, isn't it?
3 to 5 minutes. 3 to 5 minutes, sir.
No,
3 to 5 minutes.
T half KEO of fentanyl is 10 to 15 minutes. Ideally speaking, you should inject at least 10 minutes before. That is the best, to get the peak effect before you do a laryngoscopy and intubation. What about morphine, T half KEO? Because, suppose you want to inject morphine at the end of surgery to produce post-op analgesia, because morphine is routinely used for post-op analgesia, isn't it? So, or, during the post-op period, you want to use morphine for post-op analgesia, because you can also use it as a patient-controlled analgesia or PCA pump also. Fentanyl is also can be used PCA pump. For all these things, once you know T half KEO, then you know when to inject. What about morphine? When, how much time it takes to have the peak effector concentration in the brain?
30 minutes, sir.
That means if you inject 30 minutes before the close of surgery, it is enough, is it? Or it can start immediately. The patient will have very good post-op analgesia. No, that, why I'm telling you the importance of this T half KEO, because you might have read, but you may not have understood this, why this
Yes.
is important as far as T half KEO is concerned. The equilibration constant between plasma concentration and the effector site concentration. So it is 60 to 90 minutes is for morphine. Suppose if you want, when the patient, you are, the closure is over and then you want to extubate the patient and you want morphine to start acting in the postoperative period, immediately the patient is awake, you should at least inject morphine 60 minutes before. Now you understood, isn't it?
Yes.
What is the importance of T half KU? What about T half KU of, remifentanil, another drug which is now routinely being used. T half KU of remifentanil. How fast will be the peak plasma concentration equilibrates with the effector site concentration?
10 to 15 minutes, sir.
Don't try to guess. If you know, you tell. Otherwise, no problem. No, it is 1 to 1.5 minutes. That means, you want immediate post-op analgesia, you just start remifentanil. Just before you extubate, you just start it. So it starts, the effector site concentration will get equilibrated with the plasma concentration. It is so rapid, remifentanil. So what about alfentanil? When you should inject. Alfentanil we were using alfentanil also. Nowadays, because the introduction of remifentanil, alfentanil use has come down. It is same 2 to 3 minutes. Alfentanil is also very rapid. T half KUO is very fast. So that's how alfentanil, because when we are classifying the drugs, we also classified them as, the onset and offset of effect, isn't it? Rapid onset, rapid offset. We gave 2 examples. One is remifentanil and another is alfentanil, isn't it? So very slow onset, slow offset is morphine and even buprenorphine. Buprenorphine is again, nearly 60 to 90 minutes. This is, I'm talking about systemic administration, not intrathecal. Again, intrathecal morphine, it takes about 60 to 90 minutes to start acting. That is why morphine, when you give intrathecally in the beginning of surgery, it may not produce its analgesia immediately. And it starts producing after about an hour, even when it is injected intrathecally. Whereas when you give fentanyl, buprenorphine, intrathecally, they start acting immediately because I told you, they get absorbed into the systemic circulation and they go to the brain and the onset of action will be there. Analgesia will start off. But though the peak effect may take time, but analgesia will start. Whereas with morphine, analgesia itself will start after about 60 minutes, even when you inject intrathecally. Okay, yeah, understood about T half KEO and commonly used drugs, you should always remember about T half KEO. Systemically used, we use morphine, we use fentanyl, we use alfentanil, and we use buprenorphine, and also we use remifentanil. So these drugs, you should always remember about their analgesia when the peak effect at the effector site starts. Okay, what about their effect on the CNS? One is they produce analgesia, isn't it? That is what
Yes,
already discussed. Very good analgesia, CNS effect by acting on the mu receptors. So what other effects on the CNS? What about sedation, drowsiness, and any mood effects? Effects on the mood. Euphoria, dysphoria.
Because euphoria, sir.
Opiates will produce.
Euphoria, sir.
All opiates, do they produce euphoria?
So, mu
Very good.
mu2 receptor causes dysphoria.
Mu agonists will produce.
Dysphoria also, sir.
All mu agonists will produce euphoria.
Euphoria.
Feeling of well-being. Euphoria, the feeling of well-being and dreaming, hallucinations that can be produced. Euphoria that is how now the addiction liability, because this euphoric effect. And dysphoria, which opiates will produce dysphoria?
Dynorphins.
No, the kappa receptor agonist. The kappa receptor agonist. Now, which are these kappa receptor agonists?
Dynorphin.
Pentosylphenol, isn't it? Nalbuphine. These are all kappa receptor agonists. So by acting on the kappa receptors, they produce dysphoria. Whereas acting on the mu receptors, the opioids which are mu agonists will produce euphoria. One is that. Okay. What about, other than analgesia, what about the effect on the sleep? Drowsiness, sleep. Do they produce sleep, drowsiness in the analgesic dose? Now, for example, a person I give fentanyl, usually fentanyl is 1 to 2 micrograms per kg body weight, isn't it? We always give. So when I just gave 1 to 2 micrograms per kg body weight, say roughly 50 to 100 micrograms, do they produce severe drowsiness, severe, unresponsiveness, sleepless, sleep-like state? Do they produce the 50 to 100 micrograms when you use?
They will produce only sedation or effect they produce.
They may produce mild sedation, isn't it?
Mild sedation.
But they don't produce unresponsiveness.
Unresponsive.
Patient will be totally responsive, isn't it? As long as you are giving, the analgesic dose. They can only produce severe drowsiness and, sedation, quite a bit of sedation, when you exceed the dose, one, or when there is no pain when you give drug. When you give the drug, when there is no pain, they may produce some amount of sedation and drowsiness. And when you give excess dose, they can produce drowsiness and sedation, even when there is pain also. But the analgesic doses will not produce so much of sedation or drowsiness. The analgesic dose, what we usually therapeutic, because they are basically used for analgesia, isn't it? So why this is important? Why this is important to know? They don't produce unresponsiveness, and they don't produce, and they don't produce amnesia also. They don't produce amnesia, they don't produce unresponsiveness. Still the patient will be responding. And they don't produce, the mild sedation and even deep sedation, drowsiness they may produce. Why this is important? Still the patient will be responding. There won't be any amnesia. Why this particular effect of the pharmacodynamic effect of local anesthetic, the opiates is important. So anybody they can answer. The importance is this: they cannot be used as sole anesthetics. They don't produce anesthesia. They are a part of balanced anesthesia technique because they don't produce amnesia. They don't produce unresponsiveness. Because you have to produce, because what is anesthesia? Anesthesia is unconscious amnesia, unresponsiveness. That is anesthesia. But opiates do not produce this. That is why opiates cannot be used as sole anesthetics. That is why many times, in the olden days, we used to use high opiates along with, benzodiazepines for anesthesia, especially in those patients where, like a patient with severe cardiac failure or patient with low ejection fraction with poor left ventricular function, when you use propofol or tapentone, the patient can have a cardiac arrest. In all such patients, high dose opiate induction along with midazolam, because midazolam produces unresponsiveness and amnesia. A combination, because anesthesia is hypnosis and analgesia. So opiates do not produce hypnosis. That is one thing, their effect on the CNS you should always know. Okay, they produce fantastic analgesia and they produce euphoric effects, all mu agonists, whereas kappa agonists will produce euphoric. And they more than analgesic dose when you give. That is what high dose induction. They do produce unresponsiveness. Sorry, they don't produce unresponsiveness, but along with the benzodiazepine, they do produce anesthesia. That is why alone they cannot be used as anesthetics. So this you should always know. And how about the effect on the cerebral blood flow, cerebral oxygen, MRO2?
Decreasing
Decreases
cerebral blood flow.
Increases cerebral blood flow or increases cerebral blood flow? Your propofol, your tapentone, all those will reduce the cerebral blood flow. What about opiate? Opiates by them may not have a direct effect on blood flow. But all opiates produce some amount of respiratory depression. Even analgesic doses also produces some amount of respiratory depression, and ventilator response to carbon dioxide is also decreased. So invariably there can be an increase in the PSCO2. And the effect of PSCO2 is direct effect of PSCO2 on the cerebral blood flow is cerebral vasodilatation. And indirectly, opiates may increase the cerebral blood flow. And they may not have much effect on the CMR1.
Same.
So that's why, opiates are not routinely used as sole anesthetics. Okay, what about the effect of these drugs on the other, like respiratory system now, other than the CNS?
Respiratory depression.
Respiratory depression will talk along with the respiratory system effect. Because another problem with all opiates is already we have discussed is respiratory depression. Though you need not have to discuss with the CNS effect, you can also discuss that with the respiratory system effects. Now, what are the pharmacodynamic effects of opiates on the respiratory system? What about upper airway reflexes? Opiates and upper airway.
Blend the upper airway reflex.
Pardon?
Blend the upper airway reflex.
They blunt the upper airway reflexes. Very effectively, they blunt the upper airway reflexes. And what about the cough reflex?
Suppress the cough reflex.
Suppresses the cough reflex. Is it being used as an antitussive, these opiates? Antitussive, you know that.
Codeine Dex.
Yeah, codeine.
Codeine under
Yeah,
Dex.
codeine is one of the drugs that is used along with, other drugs, antihistaminics, as an antitussive drug.
Dextromethorphan.
Yeah, all opiates, they suppress the cough reflex very well. So now, upper airway reflexes are blunted and cough reflexes are also effectively blunted. What is the advantage now of using opiates?
reduces the
stimulus, intubation response,
decrease the
decrease
intubation.
the
One is
Intubation
very
response.
good that they are effectively they suppress the intubation response, especially the sympathetic response to
Response to
intubation.
intubation.
They effectively suppress the intubation response. The increase in heart rate, increase in blood pressure. That is again their effect on the cardiovascular system. That will
Cardiovascular
also.
sympathetic.
And what about the upper airway reflexes being suppressed and also the cough reflex being suppressed? What this particular effect is being utilized for?
Scoping.
Pardon?
For scoping. For laryngoscopy, you can able to.
For awake laryngoscopy?
Yes, we can able to use this.
No, you're guessing or you're telling?
For awake laryngoscopy, you can able to.
For awake fiber optic
Fiber optic
intubation.
intubation.
For awake fiber optic intubation, it can be used. One more thing is remifentanil nowadays is also another advantage of remifentanil is its use for rapid sequence induction and intubation without succinylcholine. So you read about this, we'll discuss tomorrow about how remifentanil is used for rapid sequence induction intubation when in those patients, hemodynamically unstable patients, and where you don't want to use muscle relaxants like succinylcholine. There is some contraindication. So we'll continue our discussion tomorrow. And you can also start with, a lot of doubts can be there for today's discussion. We'll start with all the doubts first tomorrow. And then we will continue with the pharmacodynamics of opioids. Okay. Right.
Thank you, sir. Thank you, sir.
Okay. So how is your preparation for exam? Going on well?
Going on.
still going on.
Still going on, sir.
No, it will be going on, definitely. Now, how it is going on, that is more important. It is good.
Start.
You are happy?
Okay, sir.
Progress? Yeah. Anyway.
Okay, somewhat okay, sir.
Okay. That's good. You should be positive. Even though you may not be reading, but you should always tell. You should be positive in your attitude. Anyway, I'm just joking. You must be studying very well. So tomorrow we'll meet again.
Okay, sir.
Okay.
Thank you, sir.
Thank you, sir.
கிளம்பிட்டாரு சார்.
Recording stop. Thank you.
ரெக்கார்டிங் ஸ்டாப் பண்ணுங்கடா.